The esophagus is a muscular transit tube autonomously propelling a bolus downward through three distinct bodily compartments. It begins in the neck at the level of the cricoid cartilage, or the C6 vertebra, and descends into the abdomen, ending at the esophagogastric junction opposite the T11 vertebra. Along this route, the tube narrows at three relative constrictions: the upper esophageal sphincter, the point where the aortic arch and left main bronchus cross, and the diaphragmatic hiatus. These three anatomical bottlenecks are exactly where swallowed foreign bodies, like poorly chewed food boluses or stray fish bones, tend to physically impact and lodge. Because this single organ spans the neck, the thorax, and the abdomen, treating esophageal disease often forces a surgeon to breach multiple distinct bodily cavities to gain adequate access. Most of the gastrointestinal tract is built with standard histological layers, wrapped in a tough outer protective membrane known as the serosa. This microscopic cross-section reveals a key anomaly. The esophagus completely lacks a serosa layer. Structural strength relies entirely on the inner submucosa and muscularis mucosae. During an anastomosis, stitching the esophagus to a gastric conduit, only these inner tissues hold sutures. This specific histological deficit makes esophageal anastomoses incredibly fragile. Compared to the rest of the gut, esophageal surgeries carry an exceptionally high risk of catastrophic postoperative leaks. At the distal end of the transit route, the tubular structure of the esophagus widens into the saccular stomach. Locating the exact point where these two organs meet, the esophagogastric junction, or OJJ, is difficult because the anatomical, histological, and endoscopic definitions do not perfectly align. Looking at this endoscopic view, clinicians often define the junction by the sudden appearance of the top of the gastric folds. Alternatively, Japanese endoscopists typically define the precise junction differently, marking it at the distal end of the palisading vessels seen here. Visible landmarks contrast with the lower esophageal sphincter, or LOS. The LOS is a physiological high-pressure zone rather than a distinct anatomical muscle ring that you can see. This invisible barrier is generated by a complex interplay between the intrinsic tone of the esophageal wall itself and the external clasp of the diaphragmatic crura. Because the lower esophageal sphincter is a dynamic pressure gradient rather than a static piece of anatomy, mechanical failures like gastroesophageal reflux disease cannot be fully evaluated through visual endoscopy alone. To map the invisible pressure dynamics of the esophagus, clinicians rely on HRM, or high-resolution manometry. High-resolution manometry is a diagnostic procedure that measures the strength and coordination of the muscles in the esophagus. Replacing older water-perfused systems, an HRM utilizes a solid-state catheter equipped with 36 circumferential sensors, spaced exactly 1 centimeter apart. This contour plot shows the data output of a normal, healthy swallow. The vertical axis represents the anatomy, and the color scale indicates pressure intensity. The sequence begins with a clear break in pressure at the UOS, or upper esophageal sphincter. The upper esophageal sphincter is the muscular valve marking the transition from the pharynx to the esophagus. This is followed by a diagonal band of body contractility, the DCI, or distal contractile integral. The distal contractile integral is a calculation that integrates the pressure and duration of the esophageal contraction over its length. Finally, the plot shows the reflex relaxation of the LOS at the bottom. This mapping allows us to define diseases like achalasia strictly by their physiological parameters, a failure of the lower sphincter to relax, combined with absent contractility in the esophageal body. This creates a dangerous clinical trap. A standard visual endoscopy will appear completely normal in 30 to 40% of patients suffering from severe achalasia. Alternatively, hypercontractile disorders will trigger uncoordinated, high-amplitude muscular spasms that trap the bolus and cause massive, localized bottlenecks. When evaluating a patient for swallowing difficulty, functional manometry is mandatory. Relying solely on structural imaging will blind the clinician to underlying neuromuscular failures. Beyond functional neuromuscular failures, the esophagus is highly vulnerable to mechanical oncological obstructions, specifically esophageal cancer. This sagittal PET CT scan demonstrates the necessity of advanced staging. PET-CT is an imaging technique that combines metabolic data from positron emission tomography with anatomical detail from computed tomography to visualize disease spread. The crucial dividing line for surgical decision-making is whether the tumor has physically invaded the submucosa. Early mucosal disease, classified as T1A, can often be cured entirely from the inside using ESD, or endoscopic submucosal dissection. Endoscopic submucosal dissection is a surgical technique using an endoscope to remove lesions from the esophageal wall while preserving the deeper muscle layers. Once a tumor breaches into the submucosal layer, classified as T1B or deeper, endoscopic scraping is insufficient, and radical surgical resection becomes required. For mid to lower esophageal tumors, surgeons utilize the Ivor-Lewis procedure, accessing the abdomen and right thorax to mobilize the stomach and resect the diseased tissue. For higher tumors, the McCown procedure adds a third stage. Surgeons make a cervical incision to pull the gastric conduit all the way up to the neck for reconstruction. Esophageal oncology is an exact science of scale. Treatment escalates from a minimally invasive mucosal scrape to a massive three-cavity anatomical reconstruction based entirely on millimeters of tissue invasion. The esophagus is highly vascularized but structurally frail, relying entirely on dynamic pressure gradients over fixed mechanical valves to function. When early diagnosis fails, the ultimate mechanical solution is a radical resection, leaving the surgeon with a physical specimen like this. Resecting this tissue safely requires an absolute understanding of that missing serosal layer to prevent devastating postoperative leaks. It also requires the knowledge that functional disorders masquerading as mechanical blockages can only be exposed via high-resolution manometry. The ultimate success of an esophageal resection rests on a total respect for the invisible biomechanical and histological rules that govern human swallowing.